Mr. Saeed, welcome to the clinic. We are here to talk today about the chemoradiotherapy treatment for your lung cancer. But I think before we start, let's do a quick recap.
Thank you, doctor, and I think I would really appreciate this because the consultation with the chest physician was a quick and brief, and I would really, can do with a quick recap.
Yeah. So you have been a heavy smoker for 17 years, correct? And recently you saw a doctor for a cough and weight loss, and they did for you a number of tests. So these tests have confirmed the presence of lung cancer that we call adenocarcinoma in your left lung. And the tumor is about 5 centimeters in size, and it is spread to some lymph nodes in the chest. Because of this, it was staged as what we call a 3A.
Yes, I know, doctor, and I know that unfortunately surgery is not possible, and that's why I've been referred to you for chemoradiotherapy, as what you mentioned.
Indeed. So we are going to talk about chemoradiotherapy thoroughly, so you understand the treatment, but I'm going to order for you further tests, namely PET-CT and MRI head, to complete all the bending staging. Well, I have actually now received the PET-CT and the MRI results, and unfortunately I have some bad news to tell you.
Go ahead, doctor.
So, while the PET-CT did not show any tumor in other places apart from the lung and the lymph nodes, the MRI brain had unfortunately showed a single lesion in your brain which looks like a secondary from your lung cancer.
I've been having some headaches for the last few days, but I thought these were about my bad eyes. It's something more serious. Can you do anything at all about it, doctor? Aggressive management of brain-only metastases, especially for 1 to 3 lesions only, with other surgery or stereotactic radiotherapy, with subsequent definitive management of the primary tumor, is considered a standard of care. Although this cohort of patients have stage 4 disease and overall have a poor outcome, some may achieve a long-term remission with aggressive therapy. One study evaluated the impact of definitive thoracic chemoradiation therapy after definitive management of synchronous solitary brain metastases treated with either surgery or stereotactic radiotherapy followed by whole brain radiotherapy in patients with non-small cell lung cancer. The median overall survival in this cohort of patients had reached nearly 30 months.
Dr. Frodo, hi.
Hi.
You are the oncology fellow, right?
Yes, I am.
Dr. Ali, the pathologist.
Yes, of course, I see you at the MDT, Dr. Ali. How can I help?
I tried to call your consultant, but he's not answering. You remember Mr. Fethi, the patient with lung cancer who we discussed in the MDT 2 days back?
Yes, he's the 48-year-old gentleman who had lobotomy 3 weeks ago for stage 2A adenocarcinoma of the lung.
Well, actually, I have received the KRAS testing for him, and it showed mutation in codon 12. Are you still going to proceed with the chemotherapy plan? Because in the MDT you decided to give him adjuvant chemotherapy.
Well, I think giving the RAS mutation, I don't think he might benefit from chemotherapy, and I think we might need to observe only. But anyway, I've discussed with my consultant for calling the patient in. But thank you so much for the heads up. This patient has stage 2A non-small cell lung cancer, and as part of the KRAS mutation, he should receive adjuvant chemotherapy. KRAS mutations occur in about 30% of lung adenocarcinoma patients, and early reports suggested a poorer outcome in patients with KRAS mutations, and hence it was postulated that RAS mutation might be associated with resistance to therapy. However, subsequent clinical studies could not always confirm the preclinical effects. A study aimed at evaluating the KRAS mutation in 4 trials of adjuvant chemotherapy versus observation in patients with non-small cell lung cancer showed that in the adjuvant chemotherapy arm, there was no significant benefit for wild-type RAS or codon 12 mutations. However, adjuvant chemotherapy had an adverse impact for patients who carried a codon 13 mutation, although those were small numbers. This study showed that KRAS status cannot be recommended to select patients with non-small cell lung cancer for adjuvant chemotherapy.
I have with me Mr. Bond, who is a 32-year-old gentleman, never a smoker, and he was referred to us yesterday from the respiratory team.
Oh, isn't he the newly diagnosed lung cancer?
Yes, exactly. He was discussed in the MDT 2 days back, and he was found to have adenocarcinoma of the right lung with liver and brain metastasis.
Right. So have you done the molecular testing?
Yes, the EGFR was done and it showed mutation, but the ALK gene is still bending.
Right. Well, this is likely going to be wild type. Do you know why? About 5% of patients with non-small cell lung cancer will harbor the ALK AML4 chromosome fusion product. This rearrangement is often found in patients who are young, never smokers, and who have adenocarcinoma histology. Presentation at stage 4, particularly brain metastases, is also very common in this group of patients. Furthermore, ALK AML4 fusions and activating EGFR mutations are mutually exclusive.
Mr. Hani, thank you for attending the clinic today. You must have heard some bad news in the respiratory clinic, and we are here to discuss all about it today.
Yeah, indeed, doctor. The news were really bad, and I'm still in shock. Because as you can see, I'm only 40 years old, fit and well, no problems, but most importantly, I've never smoked in my life. All what it is, I had a cough which lasted for a few weeks, didn't respond to antibiotics, and eventually they did a scan and then put a camera down my throat, and eventually I was diagnosed with a cancer in my right lung. But by that time, it has already spread to the liver and bones.
Well, this is a big shock, undoubtedly. With this cancer being stage 4, we cannot cure it, but we can contain it.
Thank you, doctor. I really do appreciate any kind of help. Well, in the last consultation, I was told that a number of genes will be checked and me to see if I'll be eligible for any new treatments. And I just wonder if you've got the results of those gene testing.
Yes, indeed. We have done for you several tests, and we have done molecular testing, all the EGFR, PRAF, and ALK AML4, and these were all came back as normal. And we have done also the BDL1, and the level was 5%. However, you do carry a ROS1 rearrangement, and this can be targeted by a new generation therapy.
The ROS1 gene rearrangement is similar to the ALK gene rearrangement, and some drugs can work on cells with either ALK or ROS1 gene mutations. Drugs that target the abnormal ROS1 protein include crizotinib, ceritinib, lorlatinib, and entrectinib. While crizotinib, ceritinib, and entrectinib might be used in the first line setting, the lorlatinib may be used in the subsequent line settings.
This is acting for clinical education. Like, share, subscribe.
Don't forget to check the resources down below and join us every Thursday 8 p.m. for more videos.